Okay, so I'll call the meeting to order. Can I get everyone to stand for the Pledge of Allegiance? I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Russ, can we get a roll call, please?
Brandon Earl.
Here.
Andrea Kreifels.
Here.
Sarah Lawrence. Jason Newberry. Here. Jessica Seeliger.
Here.
Robert White.
Here.
Pat Zika.
Next up, adoption of the agenda.
I move to adopt the agenda.
Got a motion, can I get a second?
Second.
Got a second. All those in favor say aye.
Aye.
None opposed, say nay. Recognition of patrons and staff. Alright, first discussion item, or only discussion item, the 2024-25 USD 353 insurance options.
Yes, so since we had a board turnover in January, I just wanted to kind of explain where we're at on this particular item. A year ago, when negotiation was ending, the WNEA and the board requested a committee be put together in order to gather options for this year's health insurance especially, but insurance options. And so both parties were represented on that committee, and so I really want to, and this has been hours of work for these people, so I really want to thank them for the time put in regardless of what happens with this. I want to make sure that they are recognized. Brianna Young and Dallas Rhodes both represented the WNEA and the teachers. Andrea Kreifels represented the board, and then Darcy and myself represented the administration, and then Stephanie Lawrence, who works on our benefits all the time, was also a part of the team to look at all this process. So it was well represented, and I appreciate all their work. They really put in a lot of time. The committee spent a lot of time talking and looking at different options, narrowed it down to 4 different companies. Last week, they were here all week, which I really appreciate. And all 4 companies came and gave presentations to the committee on their final options that they were putting forth. And so that included Legacy, Gallagher, HIC, and Heartland Benefits Group. And so not only do I now have students that I used to be in my classroom teaching for me, I now have guys back here that used to be little middle school kids in my classroom now talking to me about insurance, which is interesting. So not something that any of us ever thought we'd run into, that's for sure. But good people, and I appreciate their work on this. So the committee did all those presentations. The committee then met and discussed all of the information. And the committee is putting forth to the board, and then we'll need to put forth to WNEA. So part of this process is we are in the middle of negotiations. Your negotiations team is trying to move forward with a package with talking about salary, talking about benefits, all those things. And so they, instead of going to, the reason this meeting was called, instead of going to a negotiations meeting and talking about this and then saying, oh no, we need to go talk to the board, this allows us to talk about this tonight, and then they can go to the table with the information instead of having to schedule even more meetings than they already have. So out of the 4 brokers, we heard from all of them, and at the end of that, the recommendation that will come to you tonight, and then we'll also need to go, that recommendation will also need to go to negotiations to WNEA. After this meeting is for HIC is the recommendation, the company that is being recommended by the committee that was put together for that. And so they are here this evening, and so wanted to give them a chance to talk to you and explain their plan and what the plan that the committee decided on at the end. So
Could you first share why it was chosen? I mean, what the big difference was over the others?
sure, Darcy, you want to jump in on that?
Some of the plan benefits, they changed the plan benefits. A lot of it was also that the county, it's proven in this area. Andre, I don't know, that was a big piece.
Yeah.
Knowing how they've been with the county
The county has this.
Yeah, the county has.
12 plus years.
12 plus years, and so they know our area. They have proven with how cheap your guys' benefits are for the county is a big thing. They know our area and they know what's working. They know our doctors.
Yeah, the county has been very pleased over the years that they have worked with them, and so that was a.
They had
that was a
nothing
big
but
draw.
rave reviews from the county.
Any other questions before they come up? Okay, I'll give the floor to you guys.
Thank you.
There we go. Save the paper. I got yours still. Look at that. I packed extra packets. Would you believe that?
I got chicken scratch, but
That's quite all right. Well, David, you want to kind of
Yeah,
jump in and overview it? I'll kind of jump in where I need to here.
Kick this off. My name's David Hickman. I'm the president of the Health Insurance Cooperative Agency. And this is Matthew Hickman as well. This is one of my sons. The HIC agency was formed in about 2000 with the Kansas Hospital Association. I was hired to build healthcare plans for the Hospital Association here in Kansas. And we were very successful at doing that, working with a large pooled program. And consequently, we were also introduced to Sumner County. And Sumner County had some issues. They were with the state healthcare plan, had 2 rate increases every year. And the benefits at the same time were eroding a little bit. We've been able to, for the last dozen years, maintain a $300 deductible individual, $600 family. And we've maintained that today. That's what the benefits are at the county. And they recommended us when they found out that the district was looking at other options. I think the real difference between us and every other brokerage out there was the fact that we understand healthcare from the ground up. Working at Hospital Association, I got to see the good, the bad, and the ugly about healthcare. And when we saw something that was what I would think is egregious, have you ever had that feeling when you get hit in the stomach and you go, how could that bill be? What happened here? I'm able to explain that. And then not only explain it, but then look at resources and ways to make that purchase less expensively. I'll give you an example. Has anyone heard of the drug Humira? Okay, almost everybody, because it's a nationally advertised medication. It's been out for quite a while now, and it first came on the market at about $2,600 a month. Today, it's over $5,600 a month for the injectable. A lot of people use it. It was initially prescribed for rheumatoid arthritis, inflammation, skin conditions. Now it's very widely prescribed. Does anybody know what that drug costs a hospital, for example, through a program called 340B? Any ideas? Retails for $5,600. No ideas. This is gonna set you in the seat. This is what hit me in the stomach. 13 cents. 13 cents. Not $1, not $100, and it retails for $5,600. But yet there are some people that go to the pharmacy or specialty pharmacy can't afford the copay on the drug because of the egregious markups, rebates, and things built into the pharmacy system. That's one piece of the puzzle, just one piece. Sumner County, down the street, since 2018, we put them on a special manufacturer's drug program and a specialty importation program. We've saved them over $1 million on 49 different employees. 49 employees out of 400, we've saved over $1 million. That's in the bank account for Sumner County, not in some insurance company's pocket or pharmacy. So what we've done is we look for ways where there's opportunities to save, and then we deliver those and give options to your employees. And then because of that, we can also lower the cost or help lower the cost of the premiums that the district's paying for. It's really been beautiful because how many groups do you know in the area outside of Sumner County have a $300 deductible? We've been told it's the best plan in the community. Now the county pays a premium for that, they do, but satisfaction is very, very high. So our goal here in helping take over the plan was we got claims data, we looked at specific areas where we saw what I call bleeding. And we're gonna apply a tourniquet and help lower the cost there. So for example, pharmacy, out of control. We did an analysis and we found there's $100,000 of savings just sitting there waiting for us to turn our programs on. And the employees, every time we turn a program on like that, the employees' deductibles go to zero. We want to give them an incentive to use the best option for the county and for them. So we create positive enforcement in those plans to do that. A couple of other areas that we saw that were really driving, the claims data was amazing. The claims data, they didn't want to help us at all. The current carrier, they gave us things like how many people had COVID, how many people went in for COVID treatments. Not a big item. I mean, not 1% of the total spend. Let's focus on what's really driving cost. So we looked at that. You know what's driving cost? Diabetics. And future diabetics are, it's only going to get worse if we don't address that today. We have done a survey where we talked to a bunch of our groups and said, for a diabetic person, what's a barrier to care? What's keeping them from getting the care the doctors want and prescribe for them? And the number one thing was cost. Cost was the barrier to care. Testing and the supplies, over $100 a month on average. And then, so if someone, supplies are, let's say, $100 a month for supplies, and they're supposed to test 3 times a day, we found that they were rationing those tests. I'm gonna test once a day, and hopefully I'll stay in the range. And that's kind of sad that they're not testing because they can't afford the test. So what we've done is we went to a vendor, we found where we could get the test supplies at 60% off, same exact box, same supplies to the doctor's orders, and we could ship those free to them, the employee or the member's doorstep so they could test within compliance, keep their A1C where it needs to be, and stay out of the hospital because that average hospital stay for a diabetic is about $11,000. Pop into the ER, get the blood sugar under control or whatever. Hopefully they don't have a stroke or a heart attack because then it's going to be more money and help them manage those symptoms and in some cases even reverse those symptoms with good management. So we then found out that people were rationing their insulins. I'm just going to take enough. I can't afford another $250 copay or whatever that is. We offer it at a zero copay, shipped to the doorstep, so they can keep their insulin in the right ranges, and it's a zero copay. So we've eliminated the barrier to care. So therefore, there's really very little reason that that employee or member wouldn't want to be in compliance. So that's just a couple of things. Now I'm going to let Matt jump in here a little bit.
Sure. Yeah, I got a couple of high touch points that I want to visit really quickly. First of all, I know the plan design is big for our employees. So, and it's touched upon in our executive summary, but I see a couple of folks that have this highlighted page out right here. That's got your 2 PPO plans, not your high deductible health plans, outlined next to our recommendations for the plans that we've built out. Again, every time your members go to the primary care, I apologize. Okay. Is the one right before that or right after that? Sorry, that one's the high deductible health plan, so there just wasn't much to note on that. There's only so much you can do while keeping those plans compliant. Yeah, so again, on like primary care office visits, currently your employees or the members of the health plan are paying $30 per visit. We're gonna cut that down to $15. Specialists, we're gonna cut it in half, make those $35 visits. Emergency room, that's more of an access fee because that's gonna exist even after, or it's less of a copay, right? So it's $250, then deductible, then co-insurance. Ours is going down to $100 copay, then deductible co-insurance, but the benefit's still similar because if you are admitted, you're gonna end up with that large deductible co-insurance bill anyways, just like you currently would. Benefits we're adding, diabetic testing supplies, we're gonna ship those to your members free of charge. We are going to cover chiropractic at a $20 copay. We're currently doing that with Sumner County as well, and that's a very utilized benefit. So very good to be able to go in there for just $25 a visit. Mental health visits, again, personally, myself and our agency, we are very big on the mental health and lowering down any barriers to care there. So $10, you can go have your brick and mortar mental health visit. We also have a virtual telehealth and mental health benefit. I know when you're in a small community, sometimes the person that you want to give all your, your counseling and the therapy, you might not want to run across them at the grocery store. So we can do it virtually where it's anonymous, and that's going to happen with somebody, in a different state where you're going to be doing your counseling mental health. So really, really like that. Now in the pharmacy or below the RX there, you'll notice we're taking that generic to a $1 copay. So too often are our employees going to the pharmacy for a generic medication and being told, hey, put your insurance card up. This medication is $4 without insurance, but as soon as I run your insurance card, it's a $15 copay. So we're going to avoid that completely with the $1 generic copays. We've done that at a ton of our groups, and the member satisfaction there is extremely high. You go to the doctor's office, $15, and then you go pick up your prescription medication, and you're at $16 for the whole visit. I mean, that's pretty good, right? So we've mirrored those benefits just because on your $1,000 deductible and your $2,500, your $1,500 and your $2,500, the copay structure was the exact same. As well as your high deductible health plan. So we were able to keep in the diabetic sourcing for shipping those diabetic glucometers, test strips, Lancet solution, all of that to your member's doorstep. Even on a high deductible health plan, there's an IRS tax code that says chronic conditions, we can still send those without the employees having that first dollar copay. So even on the high deductible health plan, we're still eliminating barriers to care. I know that's important because that's going to be the low premium plan and probably where some of our lower income employees are going to be going into. So last thing I want to do is put something out there that looks appealing for low monthly premium, but then you get in it and your benefits are just, you've got a sky high deductible, you've got your max out of pocket, and before you get there, really hope you tucked away some HSA money, right? Because anything that you have is going to be deductible co-insurance. So jump in, please. Yeah.
And also in the pharmacy benefit, we're very aware of locally that we lost a pharmacy not long ago, an important partner in the community. So we also have talked with the gentleman Max that owns Caldwell Pharmacy, and those, I think he's got 3 locations now, to make sure that he is in the network and available. We don't want to lose those local partners as well. I know that there's Dillon's and I know that there's Walmart's. You can pick your pharmacy prescriptions up, but you may not like that. So we do have the ability to work locally and make sure that those folks and those suppliers are still here in the community. So thanks, Matt.
Absolutely. So I know in our talks, and I'll keep it brief, but I know in our talks, self-funding was sort of a bit of an anxious spot, right? But as David was always says, and this is my father's, this is what I learned from, I get all my anecdotes from him, but you're on a fully insured Blue Cross Blue Shield plan, try not sending in your premium next month, and you'll find out you're fully insured currently, right? You're paying so that your claims can be paid. So, this plan has a maximum liability that is $15K under your current. So we're showing some savings. That's at maximum liability. Our expected is coming in $150K under. So we got some really good underwriting there. Cost-wise, it's going to be really good. I'm still working on premium equivalents as far as 4 tiers versus 3 tiers. I'm just making sure that those line up to show nobody an increase. Just because we had a lot of people that maybe were employee plus 1 previously, and they're going to win if that's a child, but if that's their spouse, that the pricing is a little bit higher. But overall, we're going to come in lower on every tier. I just have to weight that first, okay? That's no problem.
The other thing that we're doing is, there was a concern about the plan not being in compliance as far as the Affordability Act, Patient Protection Affordable Care Act. And one of the clauses on affordability says that the district has to fund all but a small percentage of one of the plans to maintain the Affordability Act and be qualified. Your current plan didn't meet those. We are building what's called a skinny plan. And what that means is that it's a plan that probably nobody is going to sign up for, realistically. It's a high deductible, but it's going to meet the Affordability Act, so it'll keep you guys in compliance to make sure that that there's no fines or penalties. So that's just a piece that I don't know that there's anybody enrolled in that plan now, and we don't anticipate any, but we'll build that out within the 4 plans to make sure that you're in compliance.
And so on the right side of the packet, I won't get too in depth because I think when we did this with the committee, I think we spent a good hour diving through all of this data. But We've actually had our partners go in and mine some of the pharmacy data and show us real savings. So I'm going to touch on this fiduciary PBM piece right here. Having a fiduciary PBM is very important because pharmacy benefit managers make money one of 63 different ways, from rebating to spread pricing. There's all these different ways that they're going to hide how they're making money on your pharmacy. And our goal or our strategy here is to unwind all of those. We break apart your entire healthcare supply chain, and we make sure that everybody that has a piece in that healthcare supply chain has a fiduciary responsibility to make sure that the money stays in the plan where it belongs. So I'm on page 4 right here, and that's of that fiduciary PBM packet. And if you look, we've got, excuse me, that was weird. If you look, claims data starting February of 2024, running through June of 2024, we're showing $112,000 in pharmacy spend between those 2 dates. With our PBM running those exact same scripts, we would have spent $50,989. This is how we're keeping money in your bank account throughout the course of the year. We're going to be using best practices to either source prescriptions or just cut the costs out. Any rebates come directly back to you. So we actually quarterly will drive, very large checks to our clients, and it's a very good meeting because, the health insurance consultants usually aren't out delivering large checks for you to deposit back into your bank account. So those are good meetings for us. But just in your general everyday scripts, not your specialty medications even, we're already looking at cutting $112,000 every 4 months down to $50,000. So we're going to save you a ton of money there. Now the next packet is a sourcing packet. This is where we're actually sourcing your medications. As David touched on when he was talking, all of your top drugs on that Blue Cross reporting that we got are anti-diabetics. Which is great because we source those medications, right? So we're going to 5 countries that have FDA or higher standards. We're shipping those drugs right to your members' doorsteps free of charge. So these are Ozempics, Mounjaros, things that are currently $1,000 a week on a high deductible health plan, right? We're getting them for a 75% savings, shipping them directly to your members' doorsteps.
And I want to clarify something. When we say the same drug, it's the same manufacturer. It may even be part of the same lot number. The reason that other countries buy medications at a lower cost is because the countries allow them to negotiate against it. Hey, if you want your medications in our country, this is what you're going to have to do. You're going to have to compete for it. And there's the pricing. You can't just charge something and then no one's going to compete with you. And it's really sickening when you see that, a drug that is $1,264 a month, we're buying for $250. And that's delivered to the doorstep in a temperature-controlled package from the same exact manufacturer. It's sickening to see that. And it's funny, nobody is really waking up to that here locally or domestically in the United States. It's just let's let the status quo run. And I don't know who can afford to have that happen.
Yeah.
But we save hundreds of thousands, millions of dollars for our clients.
So that next page right there, that's your neighbor. That's Sumner County. Again, a client of ours for a long time. We've had this program in place since 2018, and year to date, or total savings since inception, 1.162. So over $1 million saved just on their prescription medications. That's more than your annual budget for your health insurance. So give us some time, and we're going to show you a crazy amount of savings. We're going to show you where all of this money was going before. And so, that's our goal is you can manage what you can measure, right? So the health plan that we have is fully transparent. You will be able to see where every penny is going inside of your health plan, and your members aren't going to feel like it's anything different. We're going to be using the Providers Care PPO, which is a, PPO network, meaning your members aren't going to have any special restrictions when going to providers. There's going to be a full network that they'll be able to search up either a primary care specialist and make their appointments directly with the provider. So you're not going to have any, pains in the employee satisfaction of this plan. It's going to be a very good plan. A couple more things. I really don't want to dive too deep into these things, but we are using AI to monitor the monthly reporting and using predictive modeling to figure out, where these claims are going in the future, using millions of data points that have been gathered throughout the years. Another thing we're doing is we have a foundation so that if anybody is diagnosed with, a rare or incurable disease, those can be, millions of dollars of claims. So what we do is we can actually what's called, and this is all reviewed and compliant, but what we can do is, what's the word I'm looking for here?
Well, we just set a foundation up to where the foundation will fund them in an individual policy. And it takes the liability and risk off of the group if that member wants to.
Yes.
We take them to a zero deductible,
Yes.
and then we make sure that that illness, that all the specialists are there to meet the needs of that member.
Yes.
Anybody else in the family that's let's just say that it's a dependent of a employee of the district, we would take both the employee and the dependent, put them on that plan, pay all deductibles, co-pays, all out-of-pocket costs for them to be on that plan until they're well enough to come back onto this plan. And that's within compliance of the IRS and Department of Labor.
And that can happen at any time during the year, just say.
Absolutely,
Yes.
yeah. That's a program that is, case by case basis. We're actually working that at Sumner right now, and we've got it's a life-saving benefit for some people, in all honesty, because you're removing any barriers to care they have. You're putting them in the best product they can possibly have, paying all of their out-of-pocket costs and premiums. So this is for something when something catastrophic happens, we'll be there for them.
Well, it's like, it seems like daily now that there's new innovations in healthcare.
Yeah.
And for example, a person with hemophilia. For example, do you know there was a cure for hemophilia now? Genome-specific, and do you know what the
Friend of
cost
mine
of that
works with
is?
it.
What's that?
It's ridiculous because
Yeah.
a friend of mine is a drug rep, is a rep for it, yeah.
Yeah, it's about $2 million a person. And now, our healthcare plan, what would we want to do? Well, if it was my son or daughter, I want it covered, right? Absolutely. Can your healthcare plan afford a $2 million hit for one person? Probably not. The renewal would be incredible, wouldn't it? So that's a situation where part of our foundation, we're looking for foundations that will help fund that medication for that member. In that situation, where you might not even have to take them off the plan, let's just find a way that we can fund that $2 million drug, get it to the patient, get them better, and move forward. But if you're with a plan like perhaps Blue Cross or one of the big fully insured plans, guess what they're gonna do? We exclude that drug. Go find it on your own. Go get it on your own. Good luck with that one, right? Good luck with that one. So we're gonna work hand in hand with those members to make sure that we get the best result that we possibly can for them.
Yeah. Last thing I want to touch on, and then we'll take as many questions. We'll dive as deep as you want to. But the last thing is, this is another just a value add, is a debt dismissal program. Nobody else is really talking about strategies like this, but most hospitals across the country file as a 501c3, which we all know is a not-for-profit organization, correct? Right, but we drive by them and they've always got cranes at them. Is it a 1-crane hospital or a 2-crane hospital, right? That's the question. So it doesn't make sense to us, that you get to file as a not-for-profit organization, your executives get to make buku bucks, and you still get to charge people astronomical rates compared to what you accept for Medicare. So essentially what we do is anybody that's on the plan, whether or not their full family is on the plan. So say I'm an employee and I can only afford to cover myself, okay? My 3 children will get coverage elsewhere, right? What this program does is any hospital debt that any member of our plan or family member, person that lives in the same household as a member of our plan, whether or not they're covered, we will go to bat and go to that hospital's charity, go to that hospital's foundation, or any programs they have for debt relief. So part of them filing as a 501c3, they belong to a pool of funds that is set aside by the federal government for them to use to write off medical debt for people that are in certain thresholds of income. And I believe this packet talks about it, but I believe it's 400% of the federal poverty level. That might be quite a few of our folks. So this applies for any personal medical debt. So if I'm on the health plan, but I took the high deductible and I have $6,000 that's my responsibility, the health plan paid the other $20K or whatever it was in charges, this program helps me eliminate my $6K portion. So this is something that nobody else is out there talking about. This is relief not only for your employees, but for their entire families. You'll notice that packet says $2 PEPM. We've already built that into that cost, okay? So this is just a value add. That doesn't cost you anything.
Number one reason for bankruptcies in America, medical debt. And most of it's insured.
Yeah.
But it's deductibles, out-of-pocket costs, incidentals that aren't covered.
Yeah.
And even if you think about it, if you've got a spouse or a dependent that's going through an illness like that, chances are you're not working either. You're not working at the level that you were before. So this really does help wrap that up. And it takes about 6 or 7 minutes for us, once we're on the phone, to walk through the enrollment process and get that started. And then about 6 to 8 weeks after that, we should start hearing how that's going for them in the relief. But it is something that every hospital that's a 501c3 signs up and is a part of. They just don't want to talk about it.
It's like the drug manufacturers and their manufacturers assistance programs, right? They're going to advertise the copay cards because what that does is it hits your members' deductible and max out of pocket, where then they can go in and wreck the plan for the $5K a month. What the manufacturer's assistance program does is it actually mandates that they give low income people that also don't have the coverage for that drug affordable coverage to that drug. So it's just going about getting it in the right way, and you have to look at the incentives, right? Those drug manufacturers are incentivized to make as much money as they can by selling their drugs at whatever price they want. So, a few other features. We've got navigation within our plan. So, say your member goes in and they're going to have a knee replacement done, and they're having it done at the local hospital, right? So they go up there and they're ordered to have an MRI done down the hall. Our insurance is going to call them and say, listen, you're free to go get that MRI done down the hall. You are in network. Just so you know, that hospital typically charges, $2,500 to $3,000 for those MRIs with contrast. If you go down the street to the freestanding imaging center, we're going to be able to get that to you for $300. And because you made that good financial decision, we'll eliminate your deductible. We'll just knock it down to zero because you're going to end up saving the plan a ton of money on the back end. So we're doing that for imaging. We're doing that for surgeries, trying to, get folks over into surgery centers where they can have outpatient ambulatory surgeries rather than in hospital facilities where they're exposed to, sick folks in the ER and a doctor that might have done a heart yesterday and, working on all these different things. We're going to send them to an outpatient surgery center where they're doing joints all day. So
what questions do you guys have? We've done a lot of talking.
that's right. Yeah.
So where do you guys want to start?
So, do you have is it family, single, employee, child, employee, spouse? What can I?
Yeah. So right now,
all those levels or?
Yeah, so right now you're 3-tier, right? With Blue Cross and Blue Shield. Right now what you are is employee or single,
Okay.
employee plus one, could be a child or a spouse, and then employee plus more than one is what you currently are. The way I have the rates built out right now, they're 4-tiered. So employee only, employee plus spouse, employee plus child or children, and then full family. I'm also looking at doing the 3-tiered. The directive I have is just no tier can be an increase. So I'm kind of playing with that right now, and we'll pop it out in either the 3 or the 4-tier though.
So do we know how much premiums are for each?
That's what we're waiting right now. I gotta wait that. But I did send over some numbers, yes, that are preliminary as far as just being the final set rate for that tier, because we don't even have locked down whether we're using 3 or 4 yet. But I can assure you, with our maximum plan cost being lower by $15,000 than your maximum plan cost with Blue Cross and Blue Shield, employee only, employee spouse, employee child, and family, or the 3 tiers will be cheaper than the current 3 tiers you have.
Do you have? You mentioned PPO, but I kind of must have missed whatever that was.
Yeah. Oh, providers care.
Is there out of network? Is there?
There's out of network coverage.
Did the committee see a list of all the PPO and?
So they didn't, but what we did say is that we've had that PPO at Sumner County for how long now? 5, 6, 7 years now?
Over 12.
Over 12 years, and we have no member complaints on providers. So we're very confident. I mean, they're in the same community here, and if the county employees have an issue with it, we would know about it by now. They're
Yeah, and let me back up a little bit.
Sure.
Providers Care was the old Wichita Preferred Provider organization owned by the physicians in the state of Kansas. Then it evolved to Providers Care. Providers Care is one of the biggest networks in the state of Kansas, and they're in almost virtually every community in Kansas. If you need to go to Kansas City, it spills over into the Blue Cross network. And if you spill over into Oklahoma, which we would see probably fairly readily, we have a WRAP network that covers Oklahoma and any other of the 50 states. So we do have a WRAP network as well for that.
You said self-funding. Is this one of those, is this a regular traditional policy plan, or is it one of the?
This is built like, it is built like a fully insured with the exception that it's stop loss. And what we've done is we built it so that all of that's within the current budget at maximum liability. So a specific deductible, for example, says that no one member on the plan can take any more than a certain dollar amount out of the overall budget. That number is 50,000. That's a specific. So, but what if
So
everybody?
No, say that again. I can't spend more than 50.
Well,
You won't be able to spend more than your deductible and then your max out of pocket.
the member, but to the plan, it's what's called a specific deductible to the plan. And when I say spend, meaning that the plan won't, out of their reserves, pay more than $50,000 for any one member. Okay, that's the first stopgap, called a specific deductible. But what if, you have to think, what if everybody hit that, right?
Sure.
That'd be scary, wouldn't it? Well, then there's what's called an aggregate. That aggregate says no more than a certain dollar amount. Once that's hit, the reinsurance pays. So the first stopgap is specific, no more than 50,000. The second one is if we have so many of those small claims and large claims, there's a dollar threshold called the aggregate, and once it's reached, then the reinsurance pays. The expected claims that we have are about $150,000 less than the annual budget. So we're actually under that budget with expected. We're overfunding the first year by 25%. So we're anticipating reserves, and we built the plan so that we're within the budget with that. So, and on another note, let's just say that the first day of the plan, someone has a heart attack, right? It could happen, right? It probably won't, but it could. Okay, how are we gonna afford that, right? What if the claim's $200,000? Remember, no one person can take more than 50. It's gonna take how long for the hospital to get that bill to the provider, and then how long for them to audit it and pay it? Probably we're 3 months into it before we really see a first claim, and we're funding at a fairly high level. There's no way that we're gonna exhaust the funds that are in the budget.
Well, on top of that, David's right in saying that, but on top of that, we have other features in here called like specific advance and aggregate advance, meaning the amount of those premiums that we're paying in every month. If we exceed that amount, stop loss will essentially front that money to the health plan, knowing that it will be reimbursed after 12 months of being paid out that premium. So just like a fully insured plan, you're paying your premiums in, that money is going to pay claims. Now, unlike a fully insured plan, we are able to put mitigation tools in here to actually keep that money in your bank account, and then we're going to retain 100% of the unspent claims fund. Blue Cross and Blue Shield goes and pays itself all of your money, but 18% that they're allowed to keep for profit, and then they don't show you any data to back it up. So this one will be fully transparent, and it'll have stop gaps in place. It'll feel just like that plan to you.
So like, ours went up like 30-some% because our claims were way more than any of our total premiums. So that won't happen.
No.
You have that figured, so it.
Right, yeah, that's again where the aggregate comes in. No one claim can take more than 50,000. And cumulative, those claims can take no more than the, let's just say 900,000 that is budgeted, or whatever that number is. We've got it set to where we can't exhaust that money in the plan year. But the beauty of it is if you have like 1 out of or 2 out of 5 years are a little tougher, so we've got protection for those tougher years. 3 out of 5 are good, and you've got reserves, plenty of reserves left over. You're able to keep those reserves and build them up to offset any increases in the future. That's what we've done at Sumner County. We've kept an eye on the budget. We've managed it. We put in all of our cost control features, and we've moved forward. That's why we've still got a $300 deductible, and they fund it very, very heavily as well, but it's modest increases if at all.
So no one will have more than $300 deductible?
Well, that's on the county. Your plan is gonna be almost identical to what the limits are now.
Yeah, so we did change copays on your plan, but your deductibles, maximum out of pockets, and co-insurance are not gonna change at all. Those are exactly what they were last year for employees, except for the high deductible health plan. That one, we're gonna skinny out that $6,000 HDHP.
So this is a partially self-funded plan as it's presented today with the intent of moving to a fully self-funded plan. Is that kind of what I'm hearing?
Not really. I think that partially self-funded is a good way to go and to stay.
Agreed.
I don't, a group of roughly 100 employees is a bit small to go, and self-funded, when you say that, it's never really self-funded unless you're a huge company like Zurich or someone like that. Hundreds of thousands of employees. We have never built a fully self-funded plan. We always have insurance, both specific and aggregate built in.
And who is the underlying provider? I mean, is this?
So like your claims payer would be
Okay.
Oxient. It's gonna be your third-party administrator called Oxient.
Okay.
And then we've got, so the plan partners would be, you'd have your third-party administrator paying your claims. You'd have a pharmacy benefit manager who's managing all of the, RX or the prescriptions that are coming through the plan.
What'd you say it was?
Oh yeah, so
Sorry.
in your packet
Oxient?
right there, Oxient, yeah.
So that would be like taking the place of the Blue Cross Blue Shield
Exactly.
placard?
Yep.
Okay.
That's-
Kind of, but Blue Cross Blue Shield also currently in your setting is also your pharmacy benefit manager. They're also your network. They're also your stop loss. So you're essentially going to one source to get your entire healthcare supply chain, and that's a very dangerous thing to do because they control all those
Sure.
pieces inside, and they're the ones reporting how much of your money was spent, right?
Sure.
So we're breaking apart every piece of your healthcare supply chain. Oxient is it's gonna feel like Blue Cross and Blue Shield to you and the members. It's gonna be the name on their ID card. It's gonna be the portal they log into to pull their ID cards, to pull their EOBs, to view their accumulators. Oxient would feel a lot like Blue Cross and Blue Shield, but you have stop loss carriers behind that. You have a pharmacy benefit manager. You've got the specialty sourcing solution there. You've got diabetic sourcing.
It'll all be delivered on one card,
Yep.
like Blue Cross does.
Yep.
It's all tied together very neatly, so that your employees' ease of use is they go to the provider, they show them the card, it has co-pays on it, and who the payer is, who do I send the claims to? Typically, that's done electronically today. So all of that information is on it as well, and then we have an advocacy set up in our office that if someone has a question, I don't understand this EOB. What's it mean? They're just getting, how much do I owe? What's the plan paying? What's going on here? And we have advocates. Typically, if you called Sumner County and asked them about Sarah, she's our lead advocate. Sarah is no less than amazing because when we talk, and Sarah teaches this to anybody else that's working in that advocacy customer service area, is that just because someone doesn't understand an EOB or a amount of the network discount or the copay amount doesn't mean that they're bad or anything else. It's like they just don't understand. So she talks to them in a way that you would want to be talked to. Hey, this is what it means. The explanation of benefit. Here's the date of service. Here was the provider code. Here's what they did. And there's thousands of these provider codes, and this is what it means. And then here was the billed amount, the discount amount for the network, Providers Care Network or Blue Cross, and then here's the amount that you owe. And here's how much has gone towards your deductible or out-of-pocket cost. So it's very simple, but we know how to work with your employees to engage and help them understand healthcare, which is turned into something that's fairly complicated anymore.
It's a second language.
So I like everything you guys are presenting. I think it's a good step in the right direction. That being said, I mean, everybody in this room has heard of Blue Cross Blue Shield. I have not heard of Oxient.
Sure.
So that gives me a little bit of pause.
Right?
I don't think that's enough to change my decision, but I think we definitely have to do something to change the direction of travel to our employees. We can't just keep on increasing insurance costs, and I can guarantee you that everyone that presented probably offered a similar thing of, specialized pharmacy. I get that. We had the same sales pitch down the street here a year or so ago. Now, to say that's no change to the employee, I think I would push back on that. That's a huge change to the employee because they will have to go through some different procedures to get their medicine. For instance, I know firsthand employees that have been on a particular medicine, and when they've changed to this new plan, all in cost savings, I get that, but they no longer can use the medicine that they've been using for years. They have to basically try other
Yeah.
derivatives
It's called
to
step
try.
therapy.
Right.
Yeah.
And that's fine, and I get
Right,
that, it's a
yeah.
cost saving measure, but to say that it's no change to the employee, I think is a,
This is a
maybe an
little bit
understatement.
different than step therapy, and I appreciate that. I think that's good insight. I don't necessarily agree with step therapy, and especially if the member's already been on that drug, and they may have already done step therapy to start with. We've got to go through this again, and we have found what works, so we can override that. And it's not even on this plan. We don't have step therapy in this plan.
Okay.
You know, what happens is, let's say that prescription is written. The first thing that happens is, on a medication that is a higher cost drug, is that it's pre-certified. At the point of pre-certification, when that script comes in, when we pre-certify it, we know to reach out and say, okay, maybe we fill this medication on this drug, let's fill it retail the first month. First of all, let's make sure the employee can tolerate that drug. Sometimes medications are written that someone takes it for 2 days, they go, man, this is just making me sicker. I can't do this. Why would we pay to go ahead and source things for 30, 60, 90 days when they're not gonna be taking it? They can't take it, it needs to be changed now. So we'll source it for 30 days, and if they can tolerate it, then we have reached out to the pharmacy, or we reach out to the member and say, hey, would you like that to go to a zero copay? This is what we need to do if you'd like that. But we're reaching out to them to get them engaged in it, and it's their choice too. They can say, no, I like it at my local pharmacy, that's what I'm gonna do. They don't have to do that. But it's a little different, but I appreciate your insight there.
So what, are there consequences for choosing to stay on what you want instead of what you offered,
Yeah, it's the natural consequence of probably a higher copay.
such as?
On
Yeah,
specialty
how much
drugs.
higher?
and less plan benefit,
What's that?
less plan savings, because you're not gonna
Right.
get all the
Right, I
costs.
understand
Yeah,
that,
but-
I'm
but-
just saying,
We're not real big advocates of the stick.
Yeah.
We're advocates of the carrot.
Yeah.
So what we tell them is, if you go to this option, same drug, same manufacturer, shipped to your doorstep, it's a zero copay. If you don't do that, you get to continue to make your copay that you're making now.
Yeah.
So in specialty, what is that,
It would
Matt?
be $150 plus 20% co-insurance up to a maximum cost of $250 per 30-day supply is what it currently is. That's what it would be on our plan if you did not use script sourcing. So we're not going to punish anybody, but if you want to use script sourcing, we're going to ship it to your doorstep at a $0 copay. We're going to reach out 30 days before your prescription is out so that we can do a refill and ship that to your doorstep as well. So, no stick there. You're just going to get the same benefit that you currently have. And you're right, there's probably a little bit different feel to it for the employee. But I would argue that it's, I think it's going to be a good feeling once you're getting $1 copays on your generics. We also have 300 drugs that qualify for a $0 copay that are considered, preventative medicine. So your drugs are going to be $0, $1. Worst case scenario, it's $250, or we ship it to you for free. So we've got a lot of solutions. We've got a lot of options for those employees. And while it may be different, one thing about us is we're a family agency. This is my father. He was just mentioning Sarah. That's my sister. John's my brother. He works for us. So, one thing is this is insurance, right? We like to joke and say that, Sarah speaks English and insurance, right? But the reality is every member gets my cell phone number, gets John's cell phone number, okay? I'm a single father of 3 boys. I have a 9-year-old. Today I have an 11-year-old and a 12-year-old. And so I don't sleep much anyways. You call me when you need me. I can't tell you the number of times I've answered calls on Friday, Saturday nights to get somebody an ID card to go to the pharmacy or to go to the emergency room or whatever it may be. So we do have that family feel to our agency. And we pride ourselves on, we hold all open enrollments. We don't charge anything for that. I know there's some consulting firms out there that'll add $2,500 for, holding OE meetings. We come out, we man those. We're on site quarterly, so I'm not just here when it's time to get, renewal for my payday. I'm here 4 times a year seeing if there's, any events. Can I put on a wellness fair for your teachers, right? Can we come out if you're doing a staff event just to be there? Because, insurance, you might not always have time to call me if you have a bill sitting on your kitchen table. But if I show up and I'm like, hey, do you have any, how are the benefits going for you? That might prompt you to be like, you know what? I have a question. And then how can I get you this bill? Well, you can text it to me, to be honest. So let's work this out.
I saw literature on dental, vision included too.
Yeah,
It
so dental, my rates came in really good. I've updated those since our meeting with the committee, so I think those looked really good. Dental rates, I'm going to be able to beat the current on everything. Vision, I'm way under. I don't have those in front of me today, but I can tell you, you're with Surancy. I've got a VSP proposal that's, I can get that same high allowance on the one plan. I personally think that you should offer 2 dental plans versus 2 vision plans, because right now we've got 1 dental offering and we've got 2 vision offerings, and there just doesn't seem to be. I honestly thought that your plan that offered exams and materials was your better plan, but it's cheaper than your materials only, $250 allowance. So that didn't make sense to me. I think personally you'd be better off offering 2 dentals, giving a high benefit to the folks that maybe have children that have braces and have already exhausted that $1,500 lifetime maximum. Give them a bigger benefit, give folks a $2,000 annual maximum benefit, and then create another plan that's maybe for a 23-year-old single male who's just going in for cleanings and doesn't need to pay $38 a month in premium, because that's a voluntary benefit. I could come up with a $20 or a $15 premium that's got cleanings and a $1,000 annual year maximum. That's just what that person needs. So yes, I can give you as many vision. My vision's so much under your current vision. That shouldn't be a concern at all. Vision's like $9 or $10. I'm coming in at $6. So that's not illustrated here. But I believe the dental is showing you a savings, and that was updated as of today before I printed them and came out.
We used to do 2 dental.
I have a quick question
options,
going
which was
back to the
good.
prescription.
Please.
So if you go to the clinic,
Yes.
write a prescription,
Yes.
and you take it to the pharmacy,
Yeah.
'cause if you're sick, you want it right then and there, you're gonna pay that higher copay instead of waiting for it to be mailed to you.
No. That's
No.
not going to be a specialty medication. That's
Yeah.
going to be a $1 prescription or a $0 because it's either going to go preventative or generic.
Okay.
These are Mongeros, Ozempics. These are
Your Motrin.
Skyrizis. These are expensive
like I'm watching
medications.
TV.
Yeah.
That's
Well,
what I hate
If
those
they're advertising on
I know.
TV, which
I don't
only
like
the United States and New Zealand allows, if they're advertising on TV, it's an inexpensive medication.
No,
So
it's
that Harvoni, right? We've all heard the Hep C Harvoni. You have one of those hit your plan. It's a 90-day prescription. It's $90K. So, you got to have those stops in place before those prescriptions are written.
Right, yeah, that's absolutely true.
So what did we talked, and I'll quit because I don't take it, but I've always kind of done our insurance, so I think I'm kind of smart here, but I'm just kind of, like you said, you had a heart attack day 2.
Right,
What
sure,
if I find out I have this catastrophic cancer?
Sure.
That's gonna be way over $50,000.
Sure,
You kind of explained that, but I'm talking.
okay.
There's two
Well,
options.
Let's just say you're on the $1,500 deductible plan. You're gonna hit your $1,500 deductible, then you're gonna have co-insurance, just like your plan does today. And most likely, same exact providers, okay? And then the plan will pick up and pay beyond that. But first, between what the employee has and sees as their deductible and out-of-pocket cost to $50,000 is covered by the cash flow in the healthcare plan. Once it hits $50,000, let's say the claim is $900,000. The rest of it's paid for by the reinsurance carrier. It's even advanced into the plan. And if you're over your maximum annual, then it's covered by the reinsurance anyway.
What is the maximum annual, so 50,000?
Per person, specific
right.
deductible.
Right.
The maximum annual is going to be,
It's unlimited. Under Patient Protection Affordable Care Act, they could have, you could have a $2 million claim annually, and that whole $2 million is gonna qualify
Yeah.
for it. So there's no shortcut here. And it's a qualified plan, so it meets all of the Obamacare, Patient Protection Affordable Care Act requirements. Good questions, thank you.
So what are you needing from us? negotiation
Just
team, Adam,
a
whoever.
blank check and.
Yeah. You're out of luck there.
Yeah.
Don't we need to know the premiums?
Yeah, how soon
I
can
mean,
you
how
get
soon
the
we know
final
that,
numbers
the-
for us so we can?
the dollars, because we need to have a negotiation.
Right.
settlement
Yes.
here.
But
Yes, so premiums I could have, I mean, into business tomorrow, no later, so.
We just really.
That's not something that's gonna take me very much time.
Okay, that's something we have to have before we
Right, yeah,
move on.
and it is less
My
than your
biggest concern
current.
is-
Well, and the other thing that we have that's kind of interesting with schools is that when you do your open enrollment, you're gonna have a bunch of new pairs that are opening, it's opening it up for those pairs, about 40 of them. And so that could change the census a little bit, but we're working right now to make sure that that's no problem and additional. Normally, we don't see that as a problem.
So compared to last year, your premiums and the overall picture, are we getting more for less? Are we just straight
We're
across the
getting-
board? Are we?
We're getting
You're
more for
a lot
less.
more for a little less.
Not only is the district getting more as a district, but the employees are getting a ton more because the co-pays went down. So what they're gonna notice is, what's gonna happen first in the plan? Someone's gonna have a prescription. They're gonna notice that first encounter at the pharmacy, this is great. So, I know it's clear as mud.
Real quick. So you're not gonna come back next year and,
Yes, we,
you're gonna come back next year, but you're not gonna come back with a 30% increase.
that all depends on utilization.
You've kind of seen our big picture.
Yeah.
no, so this
We
plan
have
is,
some really high things right now
Yeah,
that.
so this plan is built, to mitigate costs. We're not in here to sell you premiums. We're in here to take control of the potentially high claimants. So identifying risk, mitigating risk, that's what we're here to do.
So I get that insurance companies aren't in the business to lose money, and that doesn't matter
No.
what the company is,
So-
so.
No, but
I
our
get
goal,
that,
yeah.
so if we're hitting stop loss one after another and our
then
claims are through the
we're
roof.
gonna have a different year. We'll have a tough year, but here's what we can do. Since we've got the data, let's just say that it's, a hip replacement, a knee, a shoulder, maybe even a heart. But that heart is in better shape now. The knee's done, the hip's done. We can have that conversation, say, this is a one and done. This isn't gonna happen every year. This is not reoccurring. We can start to have the conversation. Look, we had this high-cost drug source and we saved the plan $200,000. So we had this happen the other day at Sumner County. We had a script come across, $25,000 a month for a dependent. We, within 30 days, we had that down to $6,000 cost to the plan, not $25,000 a month. And they're sourcing it, no problem. But we took the first 30 days to see, can they tolerate it? And now we've taken that $300,000 claim and turned it into about a $240,000 savings to the plan. So that's what you can expect us to do. And the employee members really aren't gonna notice that much. It is gonna be different on the pharmacy, but I've had folks tell me, they go, we've never had anybody care about the plan the way you guys do. I've never had someone reach out. Well, guess why? I'm just gonna pick on, you guys were with Aetna, okay? Aetna, you know who owns them?
With a lot of money.
CVS, paid cash for them. Aetna bought Coventry. Coventry bought a company here called Preferred Health Systems years ago. Remember Preferred Health Systems? The CEO of Aetna, guess what salary he's got over the last 10 years? Since Obamacare, Patient Protection Affordable Care Act, first 10 years, 2010 to 2020, salary. Okay, you're gonna just, I'm glad you're all sitting down. $359,944,000. And the first time I actually wrote a book about these problems called Weathering the Healthcare Storm, I did a lecture. And I don't think it was nervous, I just can't believe the numbers, right? And I said, can you imagine, just shut your eyes and just think about it. You get at the end of the month and your paycheck is $300,000 at the end of the month. $300,000. And someone goes, David, you're really bad at math. It's $3 million a month on average. Salary. So if you think that the status quo, Blue Cross, Aetna, United Healthcare, Aetna, they're here for you, they're here for a fat paycheck. You're gonna get a plan and some people are gonna be okay and happy with it. but they're gonna milk it for everything they can get. It's sad. Do you have a conscience? What would you do with 300 or 3 million a month?
I know what I'd do.
Nice things.
But Jason, real quick, to address your question, right? I can't sit here and tell you that if you have a 400% loss ratio, that we're gonna be able to bring you a flat renewal. I can't sit here in good honesty and tell you that, but what I can tell you is that, you know, you're better off in a plan where you have mitigation tools and strategies in place. Because if you have that bad year, you're gonna have it with Blue Cross or us.
No, I get it,
Yeah.
So
No.
do you wanna
I just
have
don't
it?
want you guys, I mean, I agree with everything you guys have said, I just
Yeah.
don't want you to set yourselves up for,
No,
you know, a bad situation when, well, it could happen.
Yeah, I mean,
You
it's
come
gonna
back
be,
next year and everything
Yeah.
goes up and everybody's gonna be like, well, you told us.
right. You know, I think that's realistic because 2 of 5 years are gonna not be so good. It's gonna happen. We're gonna have the hearts, we're gonna have the cancers. However, we have a cancer program. Is it in place? You know, it's just silly. Things that almost every cancer patient needs is hydration therapy. They can't stay hydrated when they're going through chemo and the radiation. Why wouldn't we put a benefit in that says, if you need hydration therapy, you don't have to go to the ER. Call us. We have a nurse come to your house and deliver it there where you're not exposed to all the other illnesses, and I can do it for $1,000 versus $10,000. It just makes sense. But if you need to go to the ER, go to the ER. We want you to go where you need to, but wherever possible, let's save some money. My father, coming from a farming family, said, I heard this on I still hear it. You have to save for a rainy day. The way you guys are now, every year is a rainy day. They spend everything that you send them, and they're gonna ask for more. And if you shop them real hard, you might get it level again, but that tells you that they made more than 15% that they could keep anyway.
Okay, I have one more comparison comment.
please.
I appreciate your answer about the prescriptions, because that was, so I either pay $300 or I can do the deductible. Okay, what about like, say I'm gonna have a surgery, and if I'm gonna have a surgery, do you find out how much that's going to cost me with that? Just say a shoulder and knee replacement.
Talk about healthcare blue book.
Yeah, so Oxient has a internal program inside of there where they can run cost metrics based upon CMS data and then data from the Providers Care Network as well. So we can see what Medicare reimbursed certain hospitals for certain procedures. We can also see what Providers Care, discount wise got from certain providers and certain hospitals. So we may reach out to you and just say, hey, listen, you're at an in-network provider. On average, we're showing that that's going to be, $52K to the health plan. If you wanted to use this other option, we could save you some money. But I think it's not going to be a carrot or a stick situation. You're never going to be penalized for using the hospital, except for responsible for how the plan benefits view that, right? So where does that line up on your summary benefits and coverages or the SPD? Is it deductible co-insurance for inpatient hospital and facility charges? Is there a benefit tied to it? So if you're inpatient for a surgery, you're asking me, are you going to be penalized, or can we tell you if there's a cheaper option? Yes is the answer. We can tell you that there's a better option, and if you still decide to go to the hospital facility because maybe that's where you feel more comfortable, you're still going to be subject to the plan benefits, so you're not going to be penalized.
Nothing changes.
So, when you say hospital, do you mean a hospital, or
It could be a
lots
clinic.
of these places, just have an overnight stay
Well,
for.
th-
Does that
this-
count as a hospital?
This tool will look at all the providers that do that procedure in the surrounding area, and it'll say, 5 miles from you, this provider, and here's their cost, and here's their quality matrix. Here's how quick that person, the average person returns to work. Here's how often they get a reinfection, readmittance to the hospital. So it's got all of that data at your fingertip. And you can use it how you want. You don't even have to use it, but if you're looking, and our office can help you navigate.
I think whether it's a hospital or not, if you're inpatient, you're going to receive deductible and co-insurance charges for your inpatient visit as well as facility fees. So I mean, in that situation, you are going to receive bills. Yeah.
Yeah, so you would probably find someone, you could
We'd
find
hope that-
someone that that would do the services
Yes.
and then send me home and still be fine and great and everything's good.
Well, our
That's what-
ideal situation is cost isn't even always the number one metric that we're looking at. We're looking at quality
Yeah.
because on a Medicare plan, somebody goes in and has a surgery, but that surgery doesn't take or they need to have it done again. Medicare doesn't pay twice, but on a private health insurance plan, the hospital bills the insurance plan twice. So our goal is to get you to the best quality facility so that you have that operation one time and then you're back to life. That's our goal. So yes, we will look up and recommend cost and quality leaders. But again, it's you're going to be able to go anywhere in that PPO network that you desire.
Ultimately, it's your decision.
And I know last year when we were, looking at different things, that was what a lot of people, 'cause they don't, you don't understand that. You just hear that the company will tell you where you have to go.
Yeah, not an HMO.
And so, not really that, but I mean, really it was kind of like your deal, you can go to your doctor or you can choose where
Right.
the says to go. So that really needs to be explained really well, because last year that threw a lot of people off. Okay, kept them away from going ahead with something different because you don't understand it. But so I appreciate all this and I'm sorry if I kept it
So-
away, but.
Maybe I
Ask
misunderstood,
questions I had.
I thought Adam's kind of opening was that the negotiation committee was needing some direction / maybe action by the board tonight to kind of
Yes.
move to the next step,
Yes.
so.
Yeah, this is a joint committee, so WNEA also had members of this committee as well, so I think that our 3 people on that committee need to be able to have the
Agreed.
board's support to take this back. And then I don't know if you guys are interested in working with HSC, if any of you would be available to possibly come to that negotiations meeting so you could talk with teachers as well. That's not scheduled yet, but.
Okay, yeah, just let us know when it's scheduled. We're happy to. I think as you guys walk away here and whatever time you leave, it's going to be clear as mud. Okay, it is very, it's complex, and so we're available to,
So are
come back down.
I guess what I was saying earlier is, when your negotiations team goes to the table, instead, if the board agrees tonight that they're interested in working with the recommendation of the committee, then these guys can work towards negotiations, these guys can come talk to WNEA without them having to come back to the table to talk to the
So
entire
you
board
want,
again.
are we needing formal action or are we needing a consensus?
Did the other plans know the cost, what am I trying to say? What I just asked you guys,
The premium, the fully
Did you
insured
know the
premium
premiums for the
equivalence
other
is what
ones?
she's.
for the other
Shaking her head,
people
yes.
that shared.
The breakdown of how much the employee needed to pay?
Yeah, what my premium would be monthly, so none of them had the premiums
Most of
figured
them
out.
were saying they would stay the same.
Yeah.
But they, yes, when we were asking, hey, what would the employee, it was most of them saying they would at least be at the same of what.
We were under.
That's what, are we basically, because Sumner County has these guys that were,
We were 14% under.
can you share why the committee decided, or no?
That was,
Well, I would make a motion that we accept the proposal from the insurance committee to work with HIC.
Got a motion on the floor, can we get a second?
I would second that, yeah, go ahead.
Got a second?
One little caveat, in the past, I just, and I know the negotiation committee will do a great job of this, and I appreciate everybody that's put the effort in. Just make sure we don't, in the process of piecemealing the negotiation, that we don't give up our bargaining positions, so we've done that in the past, so just be cautious of that.
Got a motion, and we got a second? All those in favor say aye.
Aye.
Anyone opposed, same sign?
No. It's just because
That's the
the
last
other stuff.
action.
It's not personal.
Meeting is adjourned. Thanks, meeting is adjourned. Thank you everyone for coming.
Thank you.
Thank you very much.
Thanks. You did a good job.
Thank you.
I like that.
Good job.
Say why you
Justin,
Can you say why, can you say what